I will be talking a little bit about a new product that I wouldn't say it's old. I would say maybe a product that all of us are quite familiar with now, but being the science has advanced that product, I would say, a little bit further so that it gives more comfort and more quality of life to our patients. And that new product, which hopefully we will be able to use soon, is Fexo, which is a fixed dose combination of pertuzumab and trastuzumab in subcutaneous form. These are the disclaimers. And at the outset, I will say I have not used this product as of now. And if maybe some of the faculty has used it, we will maybe get their experience at the end of it. But I do look forward to using it soon. And therefore, this was a good, I would say this is a good overview of the product and how to use the product for all of us who, in our, who are all practicing clinicians. So all of us are, quite comfortable, quite familiar with the standard of care for HER2 positive breast cancer, both in the neoadjuvant, adjuvant, and metastatic setting, where the combination of pertuzumab and trastuzumab with chemotherapy has really transformed patients' life, I would say, has given us better clinical outcomes. In the neoadjuvant setting, this combination with chemotherapy has shown to have an improved path CR. In the adjuvant setting, trastuzumab plus pertuzumab plus chemotherapy reduces the risk of recurrence or death as compared to trastuzumab and chemotherapy alone. And we are all familiar with the Cleopatra study that showed almost an increase of 12 to 13 months PFS, and almost 6.5 months increase PFS from 12.4 to 18.5 with the combination combination of targeted agents and chemotherapy as compared to just the single targeted agent with chemotherapy alone. And the difference in median overall survival was 16.5 months. So none of us are denying that this combination has huge clinical benefits to our patients, but we also all recognize that there are several challenges to treating our patients with this combination. And just a short look at the algorithm the algorithmic approach that we all use when we're seeing a newly diagnosed patients with HER2 positive early breast cancer. Most of us, if the tumor is more than 2 centimeters or node positive, will apply a neoadjuvant approach where we would give the combination along with chemotherapy for about 4 to 6 cycles, then surgery, and depending on whether there is residual disease or not, if there is path CR, most of our patients would go on to just the maintenance therapy alone, but if there is residual disease, then they would use the alternative agent of TDM1. So by and large, I would say most of our patients should fall into this side of the algorithm, because very few of our patients are really picked up when the disease is less than 2 centimeters. But if they are, then most of them would then just go ahead for surgery. And if they have, less than 2 to 3 centimeters tumor with no lymph nodes, I have also changed my practice. I just give trastuzumab paclitaxel combination followed by trastuzumab maintenance alone. But if there are some, surprises in the surgery and the disease is more than what we thought it was initially, and it's lymph node positive, then of course we would do the full adjuvant therapy of ACTHP followed by the maintenance therapy alone. But like I said, there are several challenges because the combination of pertuzumab and trastuzumab leads to long, I would say, chemo chair time, because each infusion, pertuzumab over 30 to 60 minutes, followed by an observation of 30 to 60 minutes, depending on whether you're doing the maintenance or loading, and trastuzumab. Generally, the first infusion over 90 minutes, and then if they tolerate it well, 30 minutes in the maintenance setting. And there too, you have to observe the patients for anywhere between 2 to 6 hours. So preparing these drugs takes longer. And we all know that most of our patients' veins kind of give way. And in fact, if a patient is HER2 positive, at the outset, most of us would tell them to get a chemoport or a PICC line. That itself has its challenges, especially in our country. I would say the care of the PICC lines and the increased risk of infections that we see in patients who have a chemoport or PICC line is well established, and sometimes we have to pull out the indwelling catheter. So, it is not a very easy thing for the patient, and not only does it come with increased costs, increased time in the hospital. A number of difficulties are there, and that's where we come up with this combination. I think this is like this novel formulation, I would say, because this is the first formulation of two monoclonal antibodies, both pertuzumab and trastuzumab, in a single vial for subcutaneous injection. We know that trastuzumab had already received approval for subcutaneous injection prior, but till this combination was introduced, of course, pertuzumab was not being used in subcutaneous formulation. So this combination contains the same antibodies that are approved for intravenous pertuzumab and trastuzumab. The new thing, because one of the first things that comes to our mind is, when you give a subcutaneous injection, especially if the volume is higher, how does that disseminate from the subcutaneous area to the IV? And my biggest concern, actually, when I was going through this was, does it leave a large, like a bump or a lump under the skin? So the reason why it does not is because it's formulated with recombinant human hyaluronidase that allows the sub-Q administration and allows I would say, the dissemination of the drug fairly rapidly. And the biggest advantage, of course, of the subcutaneous injection is that it really brings down the time for administration of the monoclonal antibody. If you're giving the loading dose, which will come to the doses in that. But anyway, loading is over 8 minutes, and it's about a 15 ml solution. And if it's a maintenance, it's about a 10 ml solution, which is over 5 minutes. We are all familiar, I would say, with the mechanism of action of pertuzumab and trastuzumab. We know that it is designed for dual HER2 blockade, and the site of action or at the HER2 level, at the molecular level, is different. The trastuzumab site is a little bit closer to the cell membrane, and the pertuzumab site of attachment is actually at that part which is involved with the dimerization. So when pertuzumab gets attached, it improves the effect of the trastuzumab and decreases the HER2 signaling. So what hyaluronidase does is it allows this delivery of larger drug volume. It increases the permeability of the subcutaneous tissue, and the effect is fast, and it's also reversible. So the permeability of the tissue is restored within 1 to 2 days, and there is no lasting, I would say, damage or side effects because of the addition of the hyaluronidase to this combination. So just again, what is the reason that this formulation has this third agent in it is because it allows for the dissemination of the drug. Okay, so this is again what I was talking about, is that if you give a bolus in the subcutaneous region without this recombinant human hyaluronidase, you will be left with the drug will stay here, and the patient will have like this large lump under the skin. But when it is combined with this, as you can see in the pictures, there is nothing there's no residual lesion or lump or something in that area, and there is no discomfort per se to the patient subsequently. And of course, the first question that comes to all the clinicians' mind is the effect or the pharmacokinetics, the efficacy and safety of this subcutaneous fixed drug concentration of pertuzumab, trastuzumab the same or equivalent as giving it IV? And to answer that, we will go through how the drug development took place and what were the studies that looked at not just the efficacy, safety, but also patient preferences. So the dose finding study was this phase 1B study, which was divided in 2 parts. The first part was on healthy male volunteers to determine what would be the adequate dose. So it was a dose finding. The part 1 was dose finding. And the second part was in patients with early breast cancer. And again, it was the dose confirmation part of it. And at the end of the phase 1B study, they found that, and they selected a loading dose of 1200 milligram of pertuzumab and a maintenance dose of 600 milligram of pertuzumab. The dose of trastuzumab does not differ. It remains 600 even in loading dose, in the loading dose, and 600 in the maintenance dose. So when we talk about, there are 2 vial sizes for this Fexo. The first one is 1200 plus 600. which is your loading, and 600 plus 600, which is your maintenance. And like I said, the volumes are different. The loading dose is 15 ml and the maintenance dose is 10 ml. So, and in this, they found that there were no new safety signals. And following this, they went to the phase 3 study to look at the pharmacokinetics, efficacy, and safety of this combination. And in this, patients were about, I believe, 500 patients who were randomized 1:1 to get the chemotherapy, which could either be dose-dense AC followed by paclitaxel, or AC 3 weekly with docetaxel 3 weekly. And the two arms were pertuzumab and trastuzumab given intravenously, followed by surgery, and then the maintenance part of it, or this the trastuzumab and pertuzumab given as this fixed drug combination, the subcutaneous Fexo. And in the maintenance part, also the patients who received IV, they continued on to get IV, and the patients who received subcu continued on to get subcutaneous. The primary endpoint was non-inferiority of cycle 7 trough levels. And the reason they chose cycle 7, which, when I was looking at this, was because cycle 7 is cycle 8, the patient then is coming back for after cycle 8, if you assess the level, the patient is already going to the surgery route. So then you have to call the patient back. So just before the last dose in the neoadjuvant setting, which was cycle 8, they would be measuring the trough levels. And the reason why they chose trough levels was because it had more implication on the overall clinical outcomes as compared to the Cmax. And the secondary endpoints were basically PATH-CR, safety, overall survival, invasive disease-free survival, etc. Again, just to look at the pharmacokinetic endpoints, because that shows us the bioequivalence between the subcutaneous dosing versus the IV dosing. So when we give a drug IV, the Cmax is immediate. So all of the drug goes into the circulation, and it is not subject to distribution and elimination effects. But when you give it subcutaneously, it will take some time for it to disperse from there and reach the bloodstream, and then gradually a steady state will be reached. And as you can see here, with this combination, the trough level of the subcutaneous is actually a little bit higher than the trough level when you give it IV. And the trough levels don't correlate with outcomes as much. The Cmax levels don't correlate with outcomes as much as this trough level, which is the minimum concentration that you reach just before the next dosing. And of course, when they looked at the primary endpoint, this trough level, it was, in fact, like I told you, the subcutaneous trough levels were a little bit higher, and it exceeded the non-inferiority margins. And the secondary endpoint, so the pertuzumab trough level was the primary endpoint, and the trastuzumab trough levels were one of the secondary endpoints, and both the endpoints were met. When we look at PATH-CR, it was equivalent. 59.5, 60% in the intravenous, the patients given intravenous formulation versus 59.7, those patients who were given subcutaneous formulations. So exactly the same. Now, they also looked at PATH-CR by body mass index, and this is quite interesting and I would say intriguing for us, because there is a wide variation in the Indian population also that we see. Punjab, we see more overweight patients with breast cancer, and I guess the other areas that's not so much. But what they found, and this was again interesting, is that the weight is inversely correlated to the PATH-CR. So a patient who is underweight will metabolize these faster. And when they looked at this, they found that patients who were underweight, the PATH-CR was 100% as with the IV formulation, but lower with the subcutaneous formulation, because that patient is metabolizing the drugs faster. Now, the authors, though, they said that because the numbers were so low, they did not really make any change out of this. And what they said is that people always question that when we are used to dosing the chemotherapy according to the weight and BSA, but here, because the metabolizing of the drugs depends on your weight, even though you're giving the same dose, ultimately the levels in the bloodstream are more or less the same. So that is why the dosing is across the board same, because probably our weight influences how we use up these drugs. The safety profile, again, adverse effect, any adverse effect were almost 100% in both the IV and the subcutaneous arm, and grade 3 side effects were about 50% in both the arms. There was one death in each arm, and in fact, a little bit more patients discontinued the treatment due to adverse effects in the IV arm as compared to the subcutaneous arm. And so, quite well balanced: alopecia, nausea, diarrhea, anemia, asthenia. And again, this is kind of also reflecting our chemotherapy, side effects, because it's not just the side effect of the monoclonal antibodies. And there was no increase in cardiac dysfunction, even though the doses were higher, because remember, the overall levels in the bloodstream were not that much higher. There was no increase in neutropenia, diarrhea, mucositis, ILD. There was little difference, about 3 to 4%, in the infusion-related reactions, and the authors claimed that this was probably because even slight pain or redness at the infusion site was counted in this. So maybe people were a little bit more apprehensive about using this, and were more I would say, sensitized to recording any side effect that the patient suffered. And again, no difference in cardiac safety. So at the end of this, what they were able to prove is that the fixed dose combination subcutaneous of pertuzumab trastuzumab was non-inferior to the combination given intravenously based on the cycle 7 C trough concentrations. They showed that the PathCRs were equivalent, and they also showed that the safety was comparable, and there was no difference really in safety. So this phase 3, I would say, was a successful trial, and it led basically to the approval of this combination. Now, what about patient preferences? Because we all recognize that patient preferences is very, very important when we talk about giving any treatment. And I would just say, all of us now use bortezomib sub-Q, and when it was just introduced, we were using for patients with multiple myeloma IV, and we all know that giving sub-Q is faster and so much more easier, and patients are much more comfortable. So what about patients getting the subcutaneous formulation in breast cancer? And for that, they did a 160 patient study where patients with early breast cancer were getting the maintenance part of the pertuzumab and trastuzumab. And what they did in this study is they randomized into these two groups, where first the patient got 3 cycles IV, then they got 3 cycles subcutaneous. In the other arm, it was subcutaneous first, followed by 3 cycles IV. And then the patient selected what they wanted to get going forward based on what they saw in their experience with the IV and the subcutaneous parts of the initial portion of the trial.
My apologies, ma'am.
I have a few minutes.
My apologies, ma'am. You are left with 2 minutes to conclude your presentation. 2 minutes, ma'am.
Okay, sure. So the preference in this study was very, very strong, I would say, for the subcutaneous. 88%, 87% overall at the end of the day chose this combination of subcutaneous formulation to continue going forward in the maintenance part of it. And the reasons that they claimed was, of course, less time in the clinic and much more comfortable administration. And even the physicians and the healthcare providers, they also preferred giving the subcutaneous route as compared to the IV route, because it was quicker, less resource usage, and less drug wastages. Again, the adverse events were same, and there was no new safety signals. And most of the patients were very satisfied with 85% preferred getting the subcutaneous over the IV formulation. So I think that this is really a good thing for most of our patients. We just have to probably train and make sure that our oncology nurses are comfortable giving this combination. The patient is supposed to sit in a chair, and you only give it in the thigh. You're not supposed to give it in the abdomen, because the pharmacokinetics are lower if you give it in the abdomen. So that's just one point to be very careful about. And you alternate the sites every time, and you can't split the doses or give it at 2 different sites whenever you're giving this. Just supposed to be given slowly. We already talked about 8 minutes for the loading dose, followed by 30-minute observation, and for the maintenance to be given over 5 minutes, followed by a 15-minute observation. And I would say probably in conclusion, this formulation is the first formulation of 2 monoclonal antibodies that that giving in a subcutaneous form, it is a faster and less invasive method, and with equivalent clinical outcomes, and both in terms of the concentration, the pharmacokinetics, and the PAT-CR, but better patient preferences and preferred by patients. So probably going forward, I guess, given a choice, probably most of our patients would also prefer to use the subcutaneous formulation. Thank you.